Welcome to Connect Ovar Coffee, where we host candid conversations, make meaningful connections, and talk about the science behind ovarian and gynecologic cancers. I am Rinsi, the founder of Overcome, and today we are joined by a very special guest, Dr. Angeles Secord. So Dr. Secord is the Director of Gynecologic Oncology Clinical Trials at the Duke Cancer Institute. Raised in a healthcare environment with dad as a doctor and mom as a nurse, Dr. Secord grew up to become who she was meant to be, a world-renowned gynecologic oncologist. Dr. Secord says, I enjoy my work on female cancers because it's one of the few subspecialties to blend surgery and chemotherapy. It also gives me the chance to develop strong relationships with my patients since I get to take care of them before and during their surgery, as well as continue to see them for the rest of their lifetime. What a beautiful tribute to her patients. Thank you, Dr. Secord. Such a special treat to have Dr. Secord with us. And so join us for the next 45 minutes to an hour as we chat with Dr. Secord. And if you have any questions as we go along, please put in the comment sections below and we'll get it addressed post the discussion. This is a structured conversation, so we will get to the questions, but we'll grab it after the session. We'll share it with Dr. Secord, and as and when we receive responses, we'll post it back on our YouTube channel. So with that, a huge welcome to you, Dr. Secord, to this episode of Connect Ovar Coffee. Such an honor to have you with us.
Oh, Renzi, thank you so much. What a sweet, sweet introduction. That's so kind of you.
Thank you. It shows why you are where you are, right? So I had to mention that. So Dr. Secord, you have so much to share. I'm going to dive right in. So,
Renzi, can I ask you a quick question? Please
Yes.
call me by my first name. Angeles is totally fine.
Okay. So biomarkers are becoming increasingly more important as we move towards, more precision therapies for ovarian as well as gynecologic cancers, right? So to set the foundation for the rest of the discussion, can you tell us briefly about biomarkers? What are they and why they're important, and which biomarkers are right now influencing treatment decisions, and what are the ones that are still in research?
Well, I absolutely love biomarkers. I've loved them for, I think it's 30 plus years now. My initial work was in biomarkers of angiogenesis, and angiogenesis is a study of how tumors grow, and how they do that is they have to recruit these new blood vessels to provide nutrients and oxygen for growth, which is just fascinating to me. And so I became very interested in biomarkers of angiogenesis. And now that's morphed into just a passion of biomarkers in all things. So one of the really critical questions you asked are, what are biomarkers important? Biomarkers are important for a lot of different reasons for patients. One, it can be prognostic. It can give us information to help me counsel patients on what to expect from their cancer. So some biomarkers have a really good prognosis, and we're able to give some reassurance. And I think that's really valuable for somebody who has a new diagnosis of cancer. The other way biomarkers are important is they can help us direct the treatment that's most likely going to help that person, especially in your situation where you have a biomarker that can direct one therapy that could be really valuable to someone choosing which treatment to use, and that if they have the biomarker, they may have a greater magnitude of benefit from that treatment. Every time you're thinking about a treatment, you have to think of what are the benefits of that treatment for me, and then what are the risks and how that's going to impact my quality of life. So the biomarker can say, you're going to have a really high likelihood of benefit from this treatment, versus if you don't have the biomarker present or it's at lower levels, you may have some benefit, but it may not be that great. And so I think it's really important to help with patient in terms of counseling. And I love this idea of precision medicine. We've been talking about it for decades now. And, getting the right drug to the right person at the right time. And I really do believe we're on not just the cusp of that, we're doing that. But as we proceed in all of this research, we're going to be able to refine these biomarkers further and even do a better job. And I think being proactive in identifying the biomarkers before somebody has clinical progression, and then making treatment decisions based on that, maybe even including what type of treatment they'll get. We're not at that point yet, but I see that coming.
Wonderful. So the second part of the question that I was curious to know that there are, we started with CA-125, which is still a very important biomarker. However, I see so many new ones, right, emerging and also in, research. So what are the emerging biomarkers that you think are the most promising that you would like to share with us?
I live this every day, Renzi. So I had clinic on Tuesday. Yesterday, I had clinic in the OR, and then today I had telemedicine. And so as I'm writing my patient's note, and she just is a new diagnosis of ovarian cancer, I'm thinking these are the biomarkers I want. Number one, I want genetic testing. That is so important. And while I know it's not perceived as a biomarker per se, if you have a genetic predisposition to disease like BRCA1 or 2, that is also a biomarker to direct PARP inhibitor therapy. So I think it's really important to remember genetic counseling or testing for everyone. And we do point of care testing now so we can get that information as quickly as possible. The next one I want, and I use this all the time, is HRD. I know not everybody uses it, but I really use homologous recombination deficiency as a biomarker. It's not a great biomarker. It's not the best that we can hopefully aspire to, but it's the best that we have right now, and I find it really clinically useful. The next ones I want to get now are FR alpha, and HER2 and PD-L1. And the list is growing all the time. But those are the critical ones that I want to have. In terms of ovarian cancer, I don't find next generation sequencing, like the bigger, more expensive tests looking at the genes, as useful in patients who have high-grade serous cancer. I think that may change at some point. I definitely find it useful for patients who have these more rare kind of cancers, hopefully trying to find a biomarker that can direct treatment better. But those are the ones that I mentioned. Those are the critical ones I want to have. And you may say, well, why do you want those? I want those early so that I'm prepared. So I am hopeful when I see my patient, we get started on her treatment journey, that we are going to end up getting her cancer into remission, which is going to be awesome. And then through either she doesn't need any further therapy or through maintenance therapy, that hopefully one day we can talk about, we have your cancer cured. And that is like the pinnacle of success. That's the goal. However, we also need to be mindful that this cancer may come back. So I want this information lined up so I have plan B ready to go if my patient doesn't need it or not, because I know that if somebody has a diagnosis of recurrence, it is really hard to wait an additional few weeks to get biomarkers done. So those are the biomarkers that are going to direct therapy really quickly for me.
Thank you. So when you were talking about the biomarkers, I was thinking about the different types of ovarian cancer, right? I mean, as we know, they can be quite unique in their characteristics, high grade, low grade, all the different types of ovarian cancer. So the biomarkers that you just mentioned, are they important across the board? Because I was thinking about the KRAS mutation for the LGSOC community, for example. Tell us your thoughts on those kinds of biomarkers as well.
Great question. And the biomarkers I listed are really the ones that I'm getting are really high grade serous cancer, which is the more common one that we see of all the epithelial ovarian cancers. For low grade, yes, you're absolutely right. That's the type that I would get the next generation sequencing on because I want to know what their KRAS mutations are. I think at this point in time, we're treating patients with low grade serous cancer, and the story that the presentation of GY019 came out just showing that chemotherapy is really still the hallmark of treatment for those patients. But I think at some point we're going to get to, this is my hope, this is my crystal ball, that we're going to get to a point where if somebody has a KRAS mutation, we're going to be treating them with KRAS-directed therapy in the front line. I'm not sure if this is going to happen or when it's going to happen, but my thought is that that could potentially occur. We just have to do the necessary research, but definitely a more precision-based approach. Those are patients that I would definitely want to get testing on. And also in terms of the aromatase inhibitors in low-grade serous cancer, I am also interested in what's called ESR mutations as estrogen related. It gives you an idea if the aromatase inhibitors will work or not. If patients have an ESR mutation, which are incredibly rare in ovarian cancer, just want to give a shout out to my colleague, Dr. Stephanie Gayard, who did some of this work while she was at Duke. I learned a lot from her. It's very, very rare. In patients, it's much more common in patients with breast cancer, and it may, but it can also be induced by hormonal therapy. So if somebody has this ESR mutation, that is constituently active in terms of their hormone receptor. So you can't block it with an aromatase inhibitor. You have to use other treatment options. In patients who have a clear cell or mucinous cancer, I'm going to be really interested in other biomarkers beyond the ones I've listed. In those patients, HER2 and also mismatch repair defects. So you're absolutely right. The biomarkers shift dependent on the histologic subtype, and that's the art of medicine. Do we have to order everything versus a more directed approach? And to be quite honest, I don't know the right answer for that either. I'm just trying to be very conscientious of what I'm ordering and why.
Yeah, that makes sense. Thank you so much. So, um, when we were talking about the biomarkers, in cases where the biomarkers are borderline, how do you approach treatment decisions for such patients?
So when you say borderline, are you referring to folate receptor alpha by chance?
Anything. I mean, yeah, let's
Okay.
take folate
Yeah.
receptor, for example. It's
Um,
borderline. What would you do with that
yeah.
patient?
So, what's really interesting now, and I'm changing a little bit of my thoughts about FR alpha receptors, is the positive referred to patients who had values of equal to or greater than 75% with 2 plus or higher staining. And we do have, that's the FDA approved indication for mirvetuximab sotatercept in patients who have, or sorry, mirvetuximab soravtansine, all these names, right? I'm just going to call it MIRV.
Yes, please.
But um, and that's FDA approval based on that biomarker for MIRV in patients with high-grade serous ovarian cancer or platinum-resistant ovarian cancer. So patients who have lower levels, 25% to that 74% marker, let's say, there are guidelines in the National Comprehensive Cancer Network that allow for the use of mirvetuximab with bevacizumab in select patients who have biomarker levels within that range. So if they're not eligible for mirvetuximab as a single agent, I think mirvetuximab and bevacizumab is a really nice combination approach for those patients. And so that's what I'm doing in that situation. With HER2, the FDA approval is based on 3 plus protein expression, and that is based on gastric scoring. And gastric scoring is less robust than breast cancer scoring. So one of the things that I have to be really careful as a provider is making sure how the pathologist did that scoring. And if they used the breast cancer scoring, I'm going to go back and ask them to use the gastric scoring if they don't meet the parameters for treatment, so that if they redo the scoring and then the patient meets those parameters, I can treat them. And then the other thing to know is that the NCCN guidelines, they allow 2 plus staining for the use of trastuzumab deruxtecan, which I think has been very helpful. I think that's an area where we need to have a better understanding of who truly benefits from that drug, whether they're in the 2 plus or 3 plus range. And it's really exciting to see these new drugs come about and the amazing responses we're seeing compared to traditional chemotherapy.
Absolutely. So, staying on the biomarker for just a few more seconds, when we know that this biomarker testing is not happening uniformly across the nation. There are community hospitals that are probably missing it at the onset. So when we miss doing the biomarker testing, what are we missing to provide the patient that needs to be talked about?
Yeah.
Yeah.
Just such a great point. I think in the community, a lot of the oncologists, they have been working with trastuzumab deruxtecan or TDXD or Enhertu as patients know it. They've been working with that drug for a long time for breast cancer patients. So they're very familiar with that drug. They're not as familiar with mirvetuximab in my experience in having conversations. I am very thankful that we have all these oncologists in the community that are helping our patients, especially in more rural areas where they can't get to some of these bigger centers. And the value that they provide that community locally is unparalleled. And I think there's a lot to be said with partnering with a GYN oncologist or a medical oncologist who specializes in gynecologic cancers to work with the individuals in the community to develop, or treatment plans or have a discussion about treatment. Because in my experiencing that MIRV is just a drug that they don't have as much experience with, and they may not be aware of ordering FR alpha. And then the other area is PD-L1, which recently weekly paclitaxel and pembrolizumab with or without bevacizumab. And I know all of these drugs have how many different names, right? So we're talking about Taxol with Keytruda with or without Avastin. And I'm so used to saying generic names. So Renzi, if you need me to say the commercial
No,
name, I'm
it's
happy to
fine.
do that too.
It's fine.
I know at our center we use a lot of biosimilars, so they're even different names. So we try to use a generic name. But PD-L1 is a really important marker for identifying those patients who may benefit from that regimen. And so, as a patient in our field, I think it's incredibly important to go to your doctor and have this list of things like, um, can you tell me about my genetic testing? Can you tell me about the biomarkers that were sent? What kind of testing did I have? And if they don't have, that some of the critical ones that we're going to talk about in each of those disease groups for high grade serous, if they don't have FR alpha, HER2, a PD-L1, ask for them.
Yeah.
And there are different testing platforms. Some community hospitals or some academic centers may do some of this testing on their own, whereas there's also tests that you can send out to various different companies where you get all of that readout plus their NGS testing. And so whatever is easier for that treating physician is what I would recommend, just as long as it gets done.
Thank you. So, you are at the forefront of so many exciting initiatives, including the RINA-S trial. So tell us in detail about this trial, the eligibility guidelines, expected outcomes, and anything really that you would like to share.
Yeah, so I am really excited to be the PI for this study. It has just been amazing to work with everybody, all the patients who are willing to participate on these trials. They're just so courageous, and I'm very thankful for them to participate in trials. That's how we move things forward and get new treatments for the future. I'm also really thankful for all the research teams that have participated globally. This study enrolled in record time. We were 8 months ahead of projections, which is really incredible. So I think 8 months ahead of projections means that if this is positive, we're able to get it into the clinic faster, which is truly exciting. And then working with the entire GenMed team and the RINA-S team has been great. So this study is specifically for patients who have platinum-resistant ovarian cancer, and it doesn't matter what your FR alpha level is. We're testing that, but whatever your level is, you can come on the study, even if it's 0. Because we really want to see if there's a difference in responses based on those levels, and we wanted to make sure that nobody was left behind if they could potentially benefit. And there's always a lot of inclusion criteria with any study, so I think it's probably 4 or 5 pages of all the criteria. So it's quite a bit, but patients did have to have prior treatment with bevacizumab or Avastin. If they had a BRCA1 or 2 mutation, they did have to have prior treatment with a PARP inhibitor. And if they were eligible for mirvetuximab based on that 75% cutoff, they had to have previous treatment with MIRV. So I'm really excited in this group to see, especially if patients who got previously treated with these other therapies, what their subsequent response is. Because right now we do have a really strong clinical need for other options for patients who didn't respond to MIRV or either responded to MIRV and then came off because the tumor started to get a little larger. So I think this is going to be incredibly important. The study, the primary endpoint is progression-free survival, which is really fancy words for talking about disease control. My hope, Renzi, is that we're going to see not just improvement in disease control, that we're going to see also improvement in overall survival, that we're going to see better response rates. And I'm really hope that we're going to see better quality of life as well. If we can get all of those parameters, that would be absolutely amazing. And I'm excited to see what the final readout is for the study. I'm hoping we'll get that, by later this year or early next year.
Wonderful. So a few questions on this. You talked about the progression-free survival. That's the endpoint goal. So what is the goal?
Well, my hope is that we can at least double it and probably even triple it. The chemotherapy that we have for patients with platinum-resistant ovarian cancer, the most active one is weekly paclitaxel, and then we're adding things onto that to improve it. And the progression-free survival times range across all of these studies, but the progression-free survival time with traditional chemotherapy, if you lump them all together like topotecan, liposomal doxorubicin, and paclitaxel, it's only about 3 months. We can get better by adding bevacizumab to that, which is great, but I want to be better than 6 months. It would be awesome if we got 9, 12 months. That'd be great. But I'm not quite sure what we'll see yet.
Okay. A couple of other questions. You mentioned that they have to be pre-treated. I know we are going to get these questions. That's why I'm asking. You have to be pre-treated with Bev, and why does it have to be that and not other regimen? Can you tell us the
So
reasoning? Yeah.
if someone's not eligible for Bev in because sometimes people aren't eligible for that because they have, tumor uh, indications. For instance, if there's tumor involving the bowel wall, we don't like to treat with bevacizumab because it's increased risk. Or maybe somebody who has poorly controlled blood pressure issues or just not safe to be on bevacizumab, then those patients can still go on study. But Renzi, a lot of these decisions are really based on a registration strategy and from the FDA. So yeah, and so, if the drug does get approved, we'll have to see what the indication is. But my hope is that patients who haven't received bevacizumab could still be candidates for getting this therapy if it shows that it's, positive signal and it appears to work, that it wouldn't be not an option for them. I hope I'm stating that right. And then PARP inhibitors is just really important that a patient who was a candidate for a PARP inhibitor who had a BRCA1 or 2 mutation, that they got treated with that.
Yeah.
So that's the other part of it. So yeah, I mean, we don't always get to make all of these inclusion criteria as part of our wish list.
No,
If
that's
they
good
were,
to know. Yeah.
yeah, I mean, one of the things that, I think is really important in talking about wish list on a clinical trial, a lot of times the clinical trials require that a patient has a certain, what we call performance status,
Mhm.
so their overall health, and a lot of times it requires patients to have a performance status of 0 or 1, meaning they're really doing really, really well and they have minimal symptoms. I mean, part of my wish list is that we'd be able to offer this to patients who've had more treatment or don't have that good a performance status. And I really wish we had studies like that, maybe sometime in the future.
Wonderful. And so I'm going to go to a little deeper with the RINA-S because I think you mentioned that it's folate receptor alpha agnostic, right? The marker agnostic in the sense that
Mhm.
even if you're low, even if you're zero, you're still eligible. So if that is the case, then I'm assuming this ADC then is a potential candidate for broader use for all kinds of pre-treated ovarian cancer patients. Is that a correct statement to make?
Yeah, I mean, I'm hopeful. Like I said, mentioned, I love biomarkers. I love to be able to predict treatment based on those biomarkers. I'm hopeful what we're going to find is that there will be activity across these different levels of FR alpha in the cancers that our patients have. What we may see is that there's a greater magnitude of benefit for patients who have high expression compared to low, but we also may not see that. Or there may be a different cut point. So instead of 75%, it may be 25%. It's just we're going to have to get the data and then review that and interpret it and then decide what's best for our patients clinically.
That makes sense.
Um,
Yeah.
so, and there's all these other studies going on right now too. Like ADCs are just exploding.
Yeah.
So, there is a really exciting time. So we have ADCs that are directed against HER2. We have ADCs that are directed against Claudin-6. I know that's one that we've talked about before. There's another one against Cadherin-6 and NaPi-B2. They're just more and more coming all the time. So I think, B7H4 is another one. So it may be that we get to a point where we're running all these different biomarkers and we can say, hey, you have the highest level of this one, this is what you should get first. It's too early to get to that point yet, but that's what I'm hopefully anticipating.
That's very exciting for our ovarian community worldwide. So thank you for sharing all this information. So you also mentioned side effects for any clinical trial. Side effects is a very big
Yeah.
thing to talk about, right? From what I understand and what I read, it seems like the ocular toxicity is not likely to be seen with the RINA-S trial, but I was looking at, there were a few grade 3 or higher events to be aware of in terms of side effects with RINA-S. So what is your guidance to our overcomers when it comes to seeking this treatment, and what are the questions they should be asking their healthcare team?
Mhm. Yeah, it's really interesting with the ADCs. There's different side effect profiles based on, the payload and probably the linker. And so when I think about the ADCs out, and I'm kind of thinking of this table in front of me, there's some that cause the ocular side effects. And then you have others that cause pulmonary fibrosis or scarring in the lung. And then a lot of the ones that have the topo one payload, that's this really strong chemotherapy that's inside the antibody drug conjugate or ADC that's delivered to the cancer cell, will have what we call bone marrow suppression. So decrease in the white count, decrease in the red blood cell count, which can cause anemia and people can get really tired or need a blood transfusion, or decrease in the platelet count. And one of the things I find that the scariest is decrease in the white count because that can increase your risk of a really bad infection. Other things to watch for are diarrhea and then nausea and vomiting. And what I found is that I don't really have a great handle on understanding who's going to have a side effect or not. Some people tolerate these drugs at the higher doses and they do great. Other people, you think they're going to do great, they're really healthy, and they might have a really profound side effect like a decrease in their white count. So and you specifically asked about, I think you're asking more about RINA-S, and I'll share. We've treated a lot of patients with this on the trial at Duke. We are very careful about mitigation strategies, and that just means we want to be really proactive and reduce the likelihood of somebody having any risk of these side effects. And I do that across the board with everything because I think it's really important not to minimize it. For instance, with mirvetuximab, people have the eye issue. Well, the eye symptoms can be reversible and they may go away after a cycle or two. But if somebody has really blurry vision and all of a sudden they can't read their newspaper or they can't drive, that is a really big deal in terms of their daily quality of life. So I think it's really important that we acknowledge side effects and then we have strategies to reduce them. And so with RINA-S, I'm very careful about watching, what are their blood counts before they got on the study? Did they have any issues with a drop in their white count or an infection? Did they ever require growth factor before? How well is their kidney working? All of these things. And then based on looking at a variety of different clinical questions, we make a decision about using something called growth factor support. And we can use in either a shot the day after they get their treatment that they come back to the hospital or clinic to get, or we can do what's called a device that they can put on their arm, and then the next day it'll just discharge the medication directly. And I hoped, the reason we do that is to try to avoid that white count getting too low.
Yeah.
And having a risk of infection. And I have the patient come back in a few days to repeat their counts. I usually do it in 2 to 3 days. Like I'll sometimes even do it before, it says on the study, just because I'm ultra cautious. And if I see that white count going down, I'm on the phone calling them like, do you have any fevers? If somebody's white count gets too low, I'll start them on preventive antibiotics. If their white count is so low, sometimes, like really low, I might have them come into the hospital just to keep a close eye on them, because I find that those patients also may have other issues like a decrease in their red count or platelets. And with this strategy, we've been able to, deliver a drug, keep it safe. Sometimes people need a dose reduction. And the good news, I found that this drug is active even at a dose reduction, but I'm able to keep people on the study so that they're able to benefit from this drug and ultimately, having their tumor shrink. So very, very watchful eye. I also am very careful about anti-nausea medication because I don't want somebody to even have any nausea. So if I can be proactive in terms of anti-nausea medication before they get the treatment and then for the days following the treatment, and that makes a huge difference because I don't want people to get dehydrated because they're not getting the fluids. And then in terms of diarrhea, nobody wants that, right? So being really proactive about Imodium, which is a medication you can take to decrease diarrhea, and also talking to them patients about a brat diet, which is bananas, rice, apples, toast. So that's kind of my basic 3 things for all of the drugs that have the topo one inhibitor payload. And not all of them act that way. Like I said, it's really interesting. It can be the payload and the linker. And I think as we continue to do more research, we'll have a better understanding.
Thank you for breaking it down for us. I was just thinking, and I'm just trying to wrap my head around this. So, not just for your trial, generally, typically speaking, for all the trials, it kind of requires the patients to be pre-treated with 1 or 2 or 3 regimen. That's kind of common across the board. Now, logically, I was thinking that if a patient is newly diagnosed, and she has not been treated with anything too heavy, then would she be able to just then tolerate these drugs a little better and come into this whole clinical trial space like a little earlier than waiting until 2 or 3 or 4 regimen before she's eligible for this? I mean, logically, it's like I just want to know what the thought process goes behind selecting patients for these kinds of clinical trials.
Right. I think you're right. I do think prior exposure to this chemotherapy does have a effect on your bone marrow, because you can even see it when somebody goes for their first visit. And I'm sure patients who watch this or individuals who watch this are going to say, yeah, I've seen my counts go down
Yeah.
with each cycle. They go down a little bit more. So I think that definitely happens with subsequent regimens. And I would love to continue to see this move more and more toward the front line with all
Yeah.
of these medications. I'll also tell you, Lindsay, I'm a little bit suspicious too that there's probably something that we all have in terms of how we process drugs, which is called pharmacogenomics. We all process medication a little differently. And so some people may have a certain enzyme that works better than others. So I think that has something to do with it as well. And I'm hopeful that as we continue to do these studies, we're going to dive deeper into that question. And so that if we test, for instance, one of these enzymes in somebody, and we find that it has very low activity, then we're going to know, hey, we need to start at a lower dose for you,
Yeah.
you know. So the good news is we're making so many great strides in the research that we do. We're understanding things from the individual perspective in terms of how their body responds to the treatments, how the cancers are growing in their body and why, and then also developing these new treatments. And I think that, this is going to make a big difference in the long run.
Yeah, absolutely. Because I was wondering, in like logically speaking, if a patient is in a better health, state of health, has not been pre-treated with like, 2 or 3 or more regimens, the toxicity has not built up so much in her body with the side effects and such, she would probably be able to tolerate these treatments a little better. It means it's just my logical mind kind of questioning it. So thank you for your response to that. So we are also coming out of this year's SGO, right? The Society for Gynecologic Oncology annual meeting. I know there were several exciting advances and announcements that happened. If you could give us like the top 3 or 5 highlights from the meeting when it comes to ovarian and gynecology cancers,
Oh,
what
wow.
would
So
what
many.
would you be sharing with us?
So many. Well, so there was several abstracts in ovarian cancer I thought were really interesting. The plenary started off obviously with the relacorilant abstract,
Yeah.
which was the Rosella trial, evaluating this new first-in-class drug, which is super exciting when you have a first-in-class drug, and this is the only one that targets the glucocorticoid receptor that's currently available for us, and adding that to nab-paclitaxel, or the fancy name is Abraxane. And so the study showed that not only could you control cancer longer, but you could also see an impact in overall survival, helping patients live longer. I've actually used the drug in 3 individuals, and
Yeah.
we were very excited to get it at Duke using compassionate use program. And there's just, there's certain things that you have to know about it. It's an oral medication. You take it the day before you get the weekly treatment with the nab paclitaxel. Take it the day of and the day after. It's actually fairly well tolerated. What was fascinating to me, Renzi, is it targets the glucocorticoid receptor, right? And you think about steroids. I don't know if you've ever taken steroids before. And I had to take steroids for poison ivy once, and I took too many at a time. And I mean, I was just like buzzing. It gives you so much energy. Well, one of my patients was complaining about being more fatigued, and it was because of the medication, and that's the way the medication works. So it was pretty interesting in terms of seeing her have that side effect. The other thing to watch for that is you need to, once you're on the relacorilant, you're going to have a lower dose of the nab-paclitaxel, because it can actually, the way this drug works from your body point of view, is it can increase that amount of the drug, of the chemotherapy drug that you have in your bloodstream. So that's really important to do. And then just monitoring closely, because you can also have a decrease in your counts with this regimen as well. But really exciting news, first-in-class drug, FDA approval, available for our patients. And then we also heard about the other study, B96, which I am super excited about. We did the phase 2 study of weekly paclitaxel pembrolizumab at Duke. Dr. Robert Winham was the PI of that study at Moffitt, and he asked us to participate. Just really thankful that I had a chance to be a part of it. And the B96 was a large phase trial evaluating weekly paclitaxel with pembrolizumab, with or without bevacizumab. And that was received FDA approval for patients who have PD-L1 positive disease. And so again, in 1 year, we have these two approvals. What's interesting is they're both taxane regimens, so it's kind of how do you use those? I don't think I'm going to use them sequentially. I think I'm going to use one or the other, and it could be based on the PD-L1 expression or if patients are a candidate for bevacizumab or not. So that'll be very interesting, but two more tools that we can use to help our patients. I was really excited about the study 420, which is mirvetuximab with carboplatin, and pretty exciting response rate in patients who were PARP naive. That's what I recall. So I just think this is great in terms of moving that regimen up into this next line of therapy. And can we move it into the front line? Because not everybody benefits from paclitaxel. It's really the carboplatin that's most important. So are there certain patients that are going to benefit more from mirvetuximab than from adding paclitaxel? And then the side effects are really different, right? And so for some patients, it's really important for them not to have the alopecia,
Yeah.
or the hair loss. You can have neuropathy for both of these drugs, but with mirvetuximab, I really don't know what it would be if somebody didn't have the prior treatment with the paclitaxel. So I am probably was like most excited about those three, but overall, fantastic meeting. And it's always great to come away from a meeting knowing that you're going to change how you practice in that next week or two. Bottom line is, I think we're just also committed to helping people with these cancers, and we really want to see everyone do well.
Absolutely. And we appreciate that sentiment so much. And so, just going back to the 420, because I had not heard about that one. So, what is the status of that particular study in terms of, the option being available to the patients?
So well, right now, I don't think the doublet is available. There might be ways that people could get it, but I probably won't go into that right now. But for patients with platinum sensitive disease, it may be something to consider. With mirvetuximab, it did get NCCN listing for patients who have platinum sensitive disease with greater than or 75% FR alpha expression, which I think is a nice option for patients who have had multiple rounds of carboplatin. But this is really different in terms of having the two drugs together that they could combine safely. I'm really hopeful, Renzi, that they will do a trial bringing this into the first line
Okay.
setting.
Okay.
You know,
Thank you.
that would be great.
Absolutely. So we also had it just finished the AACR as well. So back to back two important meetings. And I was just reading about this ADC, and like you said, there's an explosion of ADCs everywhere. So I was reading about this particular one, which is QLS5132. So tell us more about what this ADC is, because they were talking about this as a very promising therapy. It's a phase 1 from what I understand. So
Yeah.
tell us a little
So
more.
phase 1 antibody drug conjugate that targets Claudin-6, and we already have another ADC that's targeting Claudin-6 as well. That's the Toral compound. So a lot of interest in this target, and about I would say, 50, I've been told over 50% of patients should have expression of this or high expression. There's certain levels of expression that are needed for the trial that we have at Duke. But I think it's a really exciting target. I think that, these different drugs will evaluate different payloads, and we'll see what happens. I do know that, this is phase 1, so hopefully it'll take the next step, going toward phase 2. I do know other studies keep moving things from phase 2 to phase 3, and also moving from recurrent disease into frontline settings.
Yeah.
So I'm really excited. We have a drug, or we have a trial that's targeting Claudin-6 that's moving into the frontline setting. That's really interesting. I think it's the Catalina-4 study. So it's evaluating it with paclitaxel or with carboplatin or all three. So that's for patients with newly diagnosed disease. So really exciting to see it move there. So we'll see what happens with this other compound as well.
Okay, wonderful. So, since you are a clinical trial investigator, I'm going to just pause on this a little bit more and ask you about the phase one studies, right? Because they're, from what I understand, it's a bit more experimental, and patients may feel a little more what's the word I'm looking for? Uncertain about signing up for phase one trials. So can you tell us a little more about what would be your guidance when it comes to, even considering a phase one trial? Why and why not? Why shouldn't, or what should I overcome?
So hard for people to make this decision. So I love clinical trials. I have a lot of cancer in my family, and so I can say I'm just a strong proponent of clinical trials for, you know, not just the people I care for in my practice, but my family members as well. Phase one is a little bit harder for people to accept because phase one, sometimes these drugs, they're first in human. So you're trying to figure out, what is the right dose to use, and is there a signal of activity, and what's the safety profile? I think a lot of times people will consider phase one maybe later in their course, but then sometimes if it's too late, then you won't be eligible. And so that's really hard. Finding that right time to be in a phase one or the right phase one study for you can be really challenging. I'm very fortunate to be at a center where we have a dedicated phase one team and they do an amazing job. And, we have wonderful clinical research nurse coordinators and clinical research coordinators that help us. If I have a patient who's on phase one, help us through the process. And then I also tell patients, for a phase one trial, I can't say for sure that they're going to have direct benefit, but there is the indirect benefit that you'll be helping so many others by being part of this research. And some people are willing to do that, and some people aren't. And I totally get it. I completely can understand and relate with that. I'm probably not answering this question as so much as a physician and a clinical trialist, but more as, a person that's working with individuals who have cancer, and you can see the struggle that people have when they're making these decisions about participating on a trial or not.
Yeah,
Sometimes,
I feel like, participating in a trial in itself is a big decision. And then when it comes to a phase one trial, it's even, like I said, it's even more experimental. And you don't, like you said, you don't know what the direction of this trial is going to be. And so I can see, as a care partner, as a family member, the hesitation that a patient family may have about phase one trials. So
what I will share is that sometimes we already know in the phase one trials, and we'll know like, oh, there's a signal here for your type of cancer.
yeah.
And that will make a difference if somebody knows, well, hey, somebody else with my cancer's had it and there's been a strong signal. Then that can help people feel more comfortable. Or they'll do what's called expanded cohorts, where just they've seen a signal. Now they're making an expanded cohort or group for a patients with that specific disease or that biomarker. And that's a lot easier for someone to do. Or let's say we have two drugs that we have been using. We know they're both active, and now the phase one study is looking at what's the right dose to combine them both. And that's also a much easier, I think, for patients to consider. But I admire the tremendous courage that our patients have, and their families too, for participating on any trial.
Yeah, thank you. So I was also reading, like, statistically speaking, this is probably the first time in history that women under the age of 65 are more likely to be diagnosed with cancer than men of in the same age group. So why do you think this is happening? And, like, more and more women, younger women, are getting diagnosed with cancer, like not just ovarian, but, all kinds of cancers. And what is it within I know we don't have a magic wand or a magic answer to this, but from treating so many patients over your decades of experience, what is it that is within our power to control the outcomes?
I really think it's multifactorial. It's across breast cancer, cancers of the uterus, predominantly endometrial cancer. Endometrial cancer, we've seen a tremendous rise since 2006, so about 20 years now, where it continues to grow. And it's colorectal cancer is another big one. So are seeing this alarming trend, and I think it has to do with environment and what we're exposed to. I think it has to do with the food that we eat. In part, some of it may be related to weight-based issues and then activity. So I'm not sure we 100% completely understand the why. Very, very interested in doing some of our studies in the environment. I worked with a med student this past year who's just really brilliant. And she's going to be an OBGYN resident. So I'm super proud of her. And she had her master's in the environmental field. And I learned so much from her. So we were looking at different areas of North Carolina and trying to link in environmental factors with endometrial cancer. And so it's work that we're continuing to do. But I find it really fascinating. So one of the things that I try to do is just really be very careful about what I'm eating, eat in moderation, try to eat healthy. I try to avoid ultra processed foods. I try to avoid fast foods at all. Like I kind of try to raise my kids when they were little to think of fast food as not being food that they'd ever want to eat. I think it kind of backfired on me a little bit now, but I think it's really important to get back to, some of those elemental, basics of putting good food in your body. So I don't have a great answer for you, Renzi. I think it's really complicated. I think it's more than one thing. But I am very hopeful because in ovarian cancer, I feel like we're making strides with genetic testing. We're identifying people who are at risk so they're able to make some decisions and get that power back of making decisions about their body, like doing risk reducing surgeries or medications that can reduce their risk of that cancer at least. So it's an alarming call for action. And I think the other part of this, Renzi, too, is an alarming call for action that we need more funding on a national level for female-related cancers that happen below the belt. So ovarian cancer, endometrial cancer or uterine cancer, and cervical cancer, vulvar and vaginal cancer are in desperate need of funding.
Absolutely. That's a critical point. And especially now that, we do need to talk about this even more, about the funding that's needed for women's cancers. Women's health in general has been overlooked for decades. So it's time that we close the gap. So, like this is another question that I know that, we don't have a perfect answer for, but with so many treatments now coming in and, like you said, so much hope upcoming, but cancer is still outpacing us in the sense that we cannot keep up with the treatments because cancer finds a way to kind of go around it seems. So where are we with this ever elusive early detection with ovarian cancer, because it has been decades and we are still chasing it. So although I feel like recently there have been a few advances with the blood testing and etc., but tell us how might we outpace
So,
cancer
Renzi, you're asking me like
eventually?
hard questions here. um, so let's see. Number one, um, can we envision a time where everyone has genetic testing at a population-based level so that you know what your cancer risks are? I think that that's not too hard to envision, honestly. And that would be about 20% of your patients who have ovarian, tubal, or peritoneal cancer. And then the other question is, well, how can we identify those patients who are at risk for these sporadic cancers, and how did that happen? And what kind of things can we do for prevention in those patients? I think that this test has been elusive for us to have a blood-based cancer detection test. I think that there was one that they studied, but it turned out that the study that they did that it wasn't that helpful, unfortunately. But that doesn't mean we stop trying. With ovarian cancer, CA-125 was a hallmark of that screening and ultrasound, and we found that despite that, it wasn't enough. So doesn't mean you give up. There are actually some really interesting studies about getting vaginal fluid secretions and looking at those for a marker of ovarian cancer. So taking, the prototypical pap test to a whole new level would be pretty
Yes.
exciting. There's this whole world of, we didn't talk about ctDNA, which I think is really, really exciting in terms of a marker of cancer and this ctDNA, minimal residual disease. But there's a whole bunch of data, and that's different than what you're asking me, but probably something we should follow up on. But I think just because we haven't found something yet doesn't mean we stop. So keep going. And then the issue with cancer outpacing us, one of the hardest things with cancer is that it becomes resistant to the drugs that we have. And what are those mechanisms of resistance? And one of the mechanisms of resistance are these multi-drug pump resistance, where the cancer cell, the chemotherapy gets in a cancer cell and it can pump it out. And it's like, this is absolutely crazy that a cancer cell could do this, but they can. So is there a way that we can shut that down? So I remain ever hopeful. And I think that there's a multi-pronged approach that we can use to combat cancer, whether it's identifying people at risk, so they can choose preventive strategies, and then identifying maybe a group that is at higher risk, but may not be because of the more common genes like BRCA1 and 2, but maybe polymorphisms in their gene. I know my division director, Dr. Burchak, has been looking at this for years and has made, I think, some great strides. So continuing to do that work of others that may be not at the higher risk that we see with BRCA1 or 2 or other mutations, but at a lower risk someday. And then is there still hope for some sort of test? And I think yes, we just don't know what it is yet.
And as you were talking, I think that, you talked about a segment which was the mutation carriers, to figure out like 20-25% of them, and the rest that like just happen out of chance. There's a third bucket here that I wanted to also mention is, people like me. Like, I have a direct family history. My mother was diagnosed with ovarian cancer. She passed from it, but I don't carry the genetic mutation. However, does that put me at zero risk? I don't think so. But, like, I feel like with my situation, and many are in my shoes, I have personally seen patients whose mom got diagnosed with ovarian cancer 10 years ago, for example, and then she gets diagnosed with ovarian cancer even though she doesn't carry the mutation. There's something that we are missing. So for people like us who have the family history but do not carry the mutation, a little bit of vigilance and a little bit of monitoring can also reduce the overall incidence, I guess. Yeah.
Well, I think these are really great points, Nancy. I have a few thoughts there. One is, I mentioned like Dr. Burchak's work looking at these more rare polymorphisms that can be associated with risk. So not these more common mutations that we know about, but something that's a little bit less common. So I think he's going to continue to do more work there. The other one is, you're absolutely right. I don't think your risk is at 0%, especially if that person in your family didn't have the mutation at all, then could there be still something else there? And right now we don't have good screening tests, but knowing the symptoms, I think, are still very important. If you start to have a change in your urinary symptoms or your bladder symptoms, or feel pelvic pressure, abdominal bloating, anything like that lasts for 2 weeks, call your doctor, go get seen. They should be doing a pelvic exam if you have pelvic pain or discomfort. Request a pelvic ultrasound. Just be a strong advocate for yourself. Even as a physician, I have to advocate for myself, for my healthcare as well. So we all need to do that. Bring a friend to go with you, or a family member. I think that can really help support you when you're in clinic. And then the other thing too that we haven't touched on is this idea of opportunistic self-injectomy. So if somebody's considering a bilateral tubal ligation for contraception or birth control, then request having your tube removed, and they can do this at the time of C-section, or if you have it after you have delivery and you're doing laparoscopically, they can remove the whole tube. The other thing one of my partners and other people in the country are working with is training our colleagues in general surgery that if they go in to remove somebody's gallbladder, to take a peek at the tubes and consider doing opportunistic self-injectomy, removing those tubes then. That may make a real difference. It's a pretty easy procedure to do. There's not a lot of serious blood vessels in those areas. We've shown that we can remove the tube safely and not negatively impact ovarian function. So this can make a really big difference in people's lives. I think there's a lot of interest in it.
I absolutely agree with you on that. So just switching, and we have talked about a lot of science. So just switching gears a little bit, wanted to know Dr. Secord. So, over the course of your career, what is something that you once believed about ovarian cancer treatment that you have seen completely change before your eyes?
Oh my goodness. Okay, this is a fun fact. This goes way back. So in the 1990s, peritoneal cancer was not recognized as a separate cancer. It was called small ovarian cancer syndrome.
Mm.
And it was not recognized that a lot of these cancers come from the fallopian tube. So that was in the 1990s. And then eventually it was recognized that small ovarian cancer syndrome was really peritoneal cancer. And, now we know that a lot of these high-grade serous cancers are actually coming from the fallopian tube, and like the poor
Right.
ovary just gets blamed for everything, you
Yeah.
know?
And
So
I
I
know.
think it's making a big difference when people are deciding, should I just have my tube removed and save my ovarian function and go back and take my ovaries out later versus having both ovaries and tubes removed. And for young women making these decisions who have a BRCA1 or 2 or the other mutations that put them at higher risk, that can be really important. So I think the studies that are out there, like the SOROC study and TUBA-WISP, are so important to help us get these answers.
Thank you. And then, if there's one thing you wish that every ovarian cancer patient and caregiver understood about their treatment options today, what would it be?
Well, treatment options, I would say biomarker, biomarker, biomarker to deliver the most effective therapy. So that I think is incredibly important that patients advocate for themselves. The most important thing I would say is know your family history. And when you see your primary care doctor or your OBGYN, because you're not going to see a GYN oncologist probably, when you see those doctors, talk about your family history and ask if you should have genetic testing. There are cases where I see a patient who, has ovarian cancer and unfortunately may have had a family history of cancer or herself personally had a history of cancer that nobody did genetic testing on. So, if we do that genetic testing, we can be really proactive and prevent 20% of these cases probably.
And 20% is a significant number. So,
Yes.
absolutely. And so, we are at the top of the hour, but I have asked you a lot of questions. What have I not asked you that you would like to share with us?
Oh, Renzi, you have asked me a lot of questions. You've asked me great questions. Um, I don't think there's anything I could possibly add.
Okay,
Although
I
I
know
do
you
want to
can add
say,
this. This is my final question that I ask all my episode guests is what message of overcoming would you like to share with everyone listening today?
oh, I will say something. Now, this is fun. Overcoming. Every time I go to clinic, my cup gets lifted up again. It gets fulfilled because I see patients that are long-term survivors, or I see family members of a patient who's a long-term survivor, and that helps me know that we are overcoming every day in this fight against this disease.
Absolutely. And you brought us so much hope with all the great science that you shared and all the new, avenues and breakthroughs that are happening like live as we speak. And so we look forward to a future, perhaps without ovarian cancer very soon. We would love to see that we have found a cure, and or we are treating this as a completely, which we are already there in terms of treating it as a chronic disease, but just making grand progress with that, so that all our overcomers can lead the life that they wish to, with the fullest quality that we talked about, and they get to enjoy every day while they're overcoming. So thank you, Dr. Secord. This has been a great conversation. It was great chatting with you. And overcomers, hope this was beneficial for you. Please share this information far and wide with anyone who may benefit from all this wisdom and insights that Dr. Secord shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep inspiring and keep overcoming. Thank you and bye.